Primary liver cancer, hepatocellular carcinoma, or HCC, is one of the most common cancers in the world and the third leading cause of cancer death. The only potentially curative treatments are ablation, surgical resection, or transplant, and by the time of diagnosis, only a third of patients are eligible for these. The liver is also a common site for metastases from primary cancers in other organs. The liver as a whole receives only approximately 25% of its blood supply via the hepatic artery, and the remaining 75% is supplied via the portal vein. However, HCC derives 75 to 80% of blood supply from the hepatic artery. Through selective catheter techniques, the arterial vessels can be occluded with embolization agents to deprive the tumour of blood and nutrients, whilst the blood supply to the remainder of the liver is maintained through the portal vein, preserving normal liver function. This is known as transarterial embolization, or TAE. Transarterial chemoembolization, or TACE, is a procedure which combines TAE with a chemotherapeutic drug. The embolic effect prolongs tumour cell exposure to chemotherapeutics. DC bead drug-eluting bead is CE mark approved for drug loading with chemotherapeutic agents and offers a new level of consistency and tolerability compared to the conventional TACE procedure. DC bead provides an effective, standardized liver-directed therapy for primary and metastatic liver cancer. DC bead is composed of a sulfonate-modified PVA hydrogel containing negatively charged sites. This unique structure allows DC bead to bind with positively charged chemotherapeutic drugs. Displacing water from DC bead, the positively charged drug binds preferentially to negatively charged sulfonate groups throughout its structure. DC bead loaded with drug may be stored for up to 14 days. Once DC bead loaded with doxorubicin is mixed with non-ionic contrast medium, it may be stored for up to 7 days. This stability time optimizes efficiencies for the pharmacy and minimizes waste of unused syringes. DC bead is delivered via a minimally invasive catheter-based procedure. The drug-loaded beads are drawn up into a syringe and mixed with non-ionic contrast medium to aid delivery and visualization. Following angiography, the catheter is inserted into the common femoral artery and then carefully positioned. For HCC, the catheter is placed as close to the tumour as possible while retaining antegrade blood flow using a super-selective approach. For some metastatic disease, a more lobar approach is preferred. DC bead is slowly administered through the catheter and carried by the arterial blood flow to the tumour. DC bead M1 has a narrow size distribution and is specifically designed to travel further into the tumour vasculature and achieve a more distal embolization. Once DC bead has reached the tumour site, a controlled and sustained release of the drug occurs. This leads to active drug levels in the tumour for at least 36 days. The released drug enters the ischemic cells, preventing DNA replication and destroying membrane proteins, which results in apoptosis and cell death. Due to the targeted nature of the drug release, studies show a significant reduction in systemic levels with correspondingly high intratumoral concentrations compared to conventional TACE. Studies have shown benefits of TACE with DC bead for intermediate HCC patients in terms of improved tumour response, survival, and reduced doxorubicin-related side effects versus conventional TACE. Promising results have also been shown in patients receiving sorafenib. The high tolerability and efficacy of DC bead with doxorubicin make it the standard of care for intermediate HCC patients, offering proven clinical and QOL benefits.